Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Welcome to today's Thinking Thoracic episode, where we will be discussing the two most recent and impactful STS analyses on lobectomy versus sublobar resection that were just presented at this year's STS annual meeting. I'm your host, Jeff Yang, and am joined by two amazing thoracic surgeons, Gavit Woodard from Yale, where she is an assistant professor of surgery, and Chris Cedar, who is the Arthur E. Diggs and L. Penfield Faber Professor of Surgery and Chief of the Division of Thoracic Surgery at Rush. We're excited to have Gavit and Chris here today to talk about their studies and also have a discussion on their insights on when they would consider a lobectomy or sublobar resection. Gavit and Chris, welcome.
Thank you.
Hi, thanks for having us.
We're excited to have you, and we'll start with Gavit's study, which was recognized as the Richard E. Clark Memorial Paper. This paper was titled Lobectomy versus Sublobar Resection in the Society of Thoracic Surgeons database, Importance of Patient Factors and Lymph Node Evaluation. Gavit, I really enjoyed your presentation. I thought the data was very compelling. And I'm curious, what got you interested in this topic?
Yeah, thank you. So we all are familiar with the two large randomized trials which have come out in the past few years, JCOG 0802 and CALGB 140503, or as we like to call it, the Altorki trial, which randomized patients to receive either, in the case of JCOG, a segment versus a lobe, and for CALGB, a wedge or a segment or some sort of sublobar resection versus lobectomy. And both of these randomized trials showed no difference in outcomes between those two groups of patients. So in our trial, we wanted to explore maybe groups on the fringes. The randomized trials included all healthy patients, all the biases that go into any randomized study in a clinical trial. So they were looking at really fit patients, younger patients, people with excellent PFTs, which is kind of who you would want to study if you're really trying to probe these differences. But that's not necessarily who we're seeing in clinic. And so the goal of our study was to duplicate the design of these randomized trials, and specifically the North American Altorki study, mirror that design, and then use the STS database and try and look at long-term outcomes by duplicating this trial. And so we were able to get at the long-term survival data by linking the STS General Thoracic Surgery database to the Medicare mortality data. We had a good linkage rate, which has kind of been duplicated in other studies. And then after doing that, we had a cohort of over 20,000 patients from the STS database who were clinical stage 1A tumors less than 2 centimeters, all clinically node negative patients, who then underwent an elective procedure, a lobectomy, or a sublobar resection. Our patients who had sublobar resections, interestingly, kind of mirrored the ratio that we saw in segments and wedges that was seen in the randomized trial. So we had a wedge rate of 68%, whereas the Altorki study had a wedge rate of 59%, so fairly equivalent patient populations. And then we took these groups and we wanted to see were there survival differences between the two. So the patient characteristics, if you just look at the STS data set, are fairly different between patients who undergo a lobectomy and patients who have a sublobar resection. In general, patients who have sublobar resection are older, they have worse PFTs, And there are a lot of differences between these groups. So we propensity match them to achieve better balance between the groups. And after doing that, what we see is overall, there is still this, it's been done in other studies. It's what we found in our study. But even when you weight the patients overall, there is an advantage to lobectomy over a sublobar resection. And that's been shown previously. Where we wanted to go with this specifically was to probe individual subgroups to see what are the differences when you're looking at older patients, maybe if you break down PFTs, separating out smoking status, because we know that not all stage 1 lung cancer is the same. People do differently. And we didn't want to lump all these patients into one group. So our whole point was to probe the subgroups.
Important data. And I'm curious, what'd you find?
So, as might be expected, in the real world setting, we did not see that there was a survival difference among certain subsets of patients between lobectomy and sublobar resection. Specifically, older patients, less healthy patients with worse performance status, and those with poor PFTs, all of those, there really wasn't a difference when you're using the STS data to look at those patients. One other important finding that I think is worth highlighting, though, is if you look at the very healthiest patients, patients with Zubrod performance status of 0, there also is no difference in this group of patients. And this is the largest group of patients in the STS data set. So it's a really powered group to look at a subgroup analysis. And there is no survival difference at all between lobectomy and sublobar resection in this group. And I would say that this is probably explained by the fact that as much balancing, propensity weighting that we try to do between patients who have a lobectomy or a sublobar resection using big databases, we never fully balance these groups. And there are differences in health that we really can't account for in a big data set. So if you just look at the healthiest patients in that whole group, there are really no differences in survival between lobectomy and sublobar resection. And so when you're looking at the whole group, you're maybe just seeing differences that are pulled down by a less healthy cohort of patients among those who get a sublobar resection or a wedge. The other thing that we probed in our study was the extent of a lymph node evaluation. And we used, again, cutoffs that were mimicking the Altorki trial, in which it was mandated that you sample at least 3 lymph nodes and send frozens on those, and patients with positive nodes were supposed to undergo a lobectomy. When we split our group of patients, therefore, patients who had 2 or fewer lymph nodes and patients who had 3 or more lymph nodes, and we really found that the patients who have 3 or more lymph nodes sampled much more closely approximate the survival of a lobectomy, whereas patients who have 2 or fewer lymph node sample have much worse survival than those who undergo lobectomy. So sublobar with 2 or fewer lymph nodes is really not equivalent to a lobectomy.
Thank you for sharing that. That's really important finding. In terms of the number of lymph nodes, I think it's just worth reminding our readers that the COC standards, it does recommend you take 1 hilar lymph node and 3 mediastinal lymph nodes from 3 different stations. For the STS, do they have that granularity of where the lymph nodes were taken?
Yeah, that's a really great question. And unfortunately, the answer is no. So our study, first of all, the numbers don't align with where the standards are for lymph node dissection cutoffs. But again, we picked these based on the trial. And then in the STS database, you purely have a number of lymph nodes sampled. You don't know which station. So you could do 3 lymph nodes, but you could sample 3 of the same station. You could do 0 level 2, 0 and 2 nodes. And so the pure number in the STS database doesn't totally get at whether or not patients were having an adequate lymph node dissection. But I would say that certainly we would all agree that 2 or fewer lymph nodes is an inadequate lymph node dissection. That patients who are falling into that group are not having enough lymph nodes sampled.
So Gavit, so far, it feels like everything you have presented when it comes to the subgroup analyses are actually very similar to the Altorki trial, where there wasn't any difference between sublobar and lobar resection. Is that correct?
Yes, that's correct. Our results aligned with the results of the Altorki study.
And then can you speak a little bit about Zubrod performance status in the subgroup analyses?
Yeah, this was something that I think is really important to highlight because repeated studies of the STS database have shown persistent differences between lobectomy and sublobar resection. And we were including a lot of wedges. The majority of our sublobar patients are patients who are undergoing a wedge resection. When we look at the Zubrod performance status 0, this is the healthiest subset of patients that you could possibly study. So you get rid of anybody that has comorbidities or other issues that might, lead to a mortality for other reasons. Uh, and that's the majority of patients in STS, 57%. The curves and the survival for sublobar resection versus lobectomy completely are overlapping. There's no difference. There's not even like a minor difference. These are identical curves for lobectomy versus sublobar resection. And I would say that probably when we look at the STS data set overall and all these other studies that have looked at the STS data set comparing lobectomy to sublobar, there are differences in patients' health that we can't fully account for, that we don't fully propensity weight for, and that are just not captured in the data that is put into the STS database that somehow contribute to these survival differences that we see. And when you just zero in on the very, very healthiest patients in this group, we really don't see any differences in survival between lobectomy and sublobar resection. And I think that that's an important point, and our curves look very similar to those from the Altorki trial. And I would say our Zubrod 0 group is the Altorki trial. That's what we were trying to capture.
That's really interesting. And I appreciate how your study, there were 20,000 patients, so you have enough power to look at these different subgroup analyses. One more part about your presentation that I thought was at the STS that was really compelling was talking about the unsuspected nodal disease situations. And can you talk a little bit more about that?
Yeah, this was a really interesting finding to us. In the Altorki randomized study, patients who had their lymph node dissected, these were sent off for frozen section. And if a positive lymph node was found, those patients underwent lobectomy. We don't know if our patients had frozen sent in the operating room, but what we do know is if a lymph node was positive on final pathology and if that upstaged the patient. And so when you look at the group of patients who had unanticipated positive nodal disease, any station, but any nodal upstaging found on final pathology, whether or not those patients had undergone a lobectomy or a sublobar resection, it didn't matter. There were no differences in survival if you had unanticipated nodal disease. And I think this gets to it in this subset of patients, the cat's out of the bag. And what is going to dictate your survival at that point is not necessarily if you are resecting additional lung parenchyma between the tumor and some draining lymph node, but really the point is whether or not you're going to properly receive adjuvant therapy and respond to that therapy. And so your survival then is driven by other things rather than the extent of your surgical resection.
Very important findings and terrific presentation at the SDS, Gavitt. Thank you for sharing this with us.
Thank you.
We'll turn to Chris's study, which was presented as a late-breaking abstract in the plenary session. This study was titled Anatomic Lung Resection is Associated with Improved Survival Compared with Wedge Resection for Stage 1A Non-Small Cell Lung Cancer. Chris, welcome.
Hi, how are you? Thank you very much.
Great. So what got you interested in this topic?
Sure. Similar to Dr. Woodard, we had looked at the previous trials, and the question that we had was, are those trials generalizable to the entire population? The best estimate of that we have would be looking at the STS database. Now, when you look at the JCOG trial, we knew that over 40% of those patients were never smokers. The median FEV1 was greater than 2 liters. They were almost all adenocarcinomas. And you look at the CLGB trial, very strict inclusion criteria, including an upfront lymph node dissection with frozen section analysis. And when we look at our own practices, I think many of us would agree those are not our patient populations, and those are not necessarily our operative practices. And so we hypothesized that in routine clinical practice, lobectomy for these sub 2 centimeter stage 1A non-small cell lung cancers may actually be associated with improved survival compared to sublobar resections. But as opposed to Dr. Woodard's study, one of the things that we were kind of most interested in looking at is, was that driven by the wedge resections or was that driven by segmentectomies, if that truly was the case?
Thank you for sharing that, Chris. Can you give an overview of the study design for your study?
Sure, absolutely. So we took the STS General Thoracic Surgery database between 2012 and 2022, so over a 10-year period, and we pulled out all the lobectomy, segmentectomy, and wedge resections of patients who got surgery for clinical stage 1A, less than 2 centimeter non-small cell lung cancer. We excluded many of the high-risk patients, including high ECOG status or ASA status, patients who had gotten induction therapy, or patients with life-limiting comorbidities such as ILD or pulmonary hypertension. We then linked those patients to both the CMS database as well as the National Death Index. And the reason that that was important was because the National Death Index, for the first time, gives us the ability to study patients less than 65 years old. We then defined our primary endpoint as overall survival, and the National Death Index data provides lung cancer specific survival or primary cause of death. So our secondary endpoint was lung cancer specific survival.
Great. And that's an important note that you had mentioned, in that I think previous studies, and maybe you could clarify this, previous STS databases that were linked to the CMS, you had only looked at folks who were over 65 years of age. Is that correct?
That's right. There have been a number of longitudinal studies that have been performed, over the last 7 or 8 years through the STS database with linkage to the CMS database. And that's given us a lot of information, and the longitudinal survival that's been presented has been it has been quite informative for the STS and thoracic surgeons in general. However, those findings can only be applied to patients greater than 65 years old, which is a great majority of the patients in the CMS database.
Got it. And then what did you find in your study?
So we had overall about 32,000 patients, and that included about 20,000 lobectomies, 4,000 segmentectomies, and about 8,000 wedge resections that were ultimately able to be linked to the National Death Index and the CMS database. Over the study period, we saw that the number of segmentectomies actually increased over time from about 9% to closer to 22%. And the percentage of wedge resections over that same time period remained stable, while the percentage of lobectomies actually dropped from close to 67% to down to about 53%. Now, our study population was reflective of the patients in the STS database, age of about 70 years old, mostly white, almost all were smokers, and about 70% of these patients had adenocarcinomas. 85% of patients had minimally invasive operations. And what we found overall, after doing our risk adjustment, was that in fact, overall survival was better for lobectomy than it was for sublobar resections. And when we broke the sublobar resections down to segmentectomies and wedge resections, that inferiority of the sublobar resections was not due to the segmentectomies, because they performed from an overall survival standpoint just as well as patients who had a lobectomy. However, when you compare wedge resections to lobectomies, there was a survival difference there, and the wedge resections are really what was driving the inferior overall survival of the sublobar resections. When we examined this group with 10-year overall survival follow-up, we went on to look at lung cancer specific survival and found the exact same findings. And so, overall, what we took away from this was that, given the biases that are present in the STS database, that we know of, that there are unrecognized confounders, and there are times when surgeons use a wedge resection as a compromise operation, you could call it, perhaps for a patient who wouldn't tolerate a lobectomy. after doing our risk adjustment, it appears that sublobar resections do still perform worse than lobectomies, and that was primarily driven by our wedge resection patients.
Very interesting findings, Chris. In the wedge resection group, previous retrospective analyses have found that a lot of times only a few or even zero lymph nodes are examined. I think back to a Cedar analysis over a decade ago, where they showed that 2/3 of patients undergoing wedge resection only had 0 or 1 lymph node examined. Did you see that similar trend in your data?
Yeah, absolutely, we did. 20% of patients who had wedge resections had no lymph nodes sampled. It's very difficult, and in fact impossible, in this retrospective type analysis to parse out, what was the survival due to? I mean, we can state there are associations, we can see that there are trends, but as you guys have discussed here already, we all agree that lymph node dissections are important, and we would all agree that a wedge resection with 0 lymph nodes taken is an inadequate operation. When you compare that to your your lobectomies and your segmentectomies that had only a 1 to 2% rate of NX pathologic staging, meaning no lymph nodes were taken, that gives you a clue of why these wedge resection patients may have done worse.
That makes sense. I think what you said does give folks who do wedge resection some hope, in that if you do a wedge resection that has that's associated with a thorough lymph node evaluation, potentially, I know your study doesn't go into this detail, but potentially you can still have very good outcomes.
I think that that's a very important point. And there was a great session at the STS where we were talking about what is a quality wedge resection. What does that look like? And that, that may include margin distance. That may include the number of nodes taken. We saw videos of people who perhaps did some hybrid operation between a segment and a lobectomy, where you take just the artery and then a gigantic wedge, things along those lines. And we don't necessarily have the answers exactly just yet. But we've all been in a situation where you have a sub 2 centimeter tumor that's right on the edge of a segment, and you're wondering, if I do a segmentectomy with a 4 millimeter margin, is that really better than a gigantic wedge resection with a 2 centimeter margin all the way around? We don't have those answers yet, but we're all thinking the same thing, and these are all questions we all have.
Exactly. And I think what you're referring to, some people, I don't know if this was actually coined by Seth Krantz, but I've heard him say it as a wedge mentectomy or something like that. There's a hybrid between a wedge and a segmentectomy, the wedge mentectomy. Great. Well, thank you, Chris. This is really terrific presentation at the STS, and really important findings here that you shared with us today. I'd like to bring in both Gavit, you and Chris, and just talk a little bit about what you feel, taken as a whole, what are the practical implications for your studies?
Sure. Well, I can get started. And I think that the main takeaway from our study is that, the randomized controlled trials involve highly selected patients at specialized centers with standardized protocols, which have the potential to overestimate benefits and underestimate harms when applied to a broader population. And we observed just that in our study, that our 5-year overall survivals were lower for sublobar resections as well as lobectomies than seen in the CALGB trial. There's a lot of reasons for that, some of which we've already alluded to, but the take-home message, I think, from our study is that unless you follow the strict selection criteria and intraoperative protocols seen on trial, that perhaps surgeons can't expect the same result. And the CALGB trial does not necessarily give free rein for anybody to just perform wedge resections on anybody who has a sub 2 centimeter tumor.
I would agree with that. I think the importance of a nodal dissection was a common theme between our studies, and that is really the critical takeaway when we're comparing sublobar to lobectomy, because a lot of those are wedges. And I would, to your point about uh, a lesion on the periphery of a segment, that patient is maybe better served with a big wedge resection and a great lymph node dissection than adhering to some strict anatomic confines of what a segmentectomy might be. So I think that making sure we're adequately staging lymph nodes is critical.
Exactly. I do feel that both your studies highlight the importance and critical aspects of a thorough lymph node evaluation. In terms of how do you think your studies are going to affect your own clinical practice?
Sure. Well, for me, I think twice about doing wedge resections, especially in healthy patients. And I do think it's important, though, as we mentioned, to remember that both of our studies demonstrate associations. They don't demonstrate causation here, and there is a difference. The General Thoracic Surgery database, as we begin to incorporate long-term outcomes into the database with National Death Index and linkage to the CMS database, we are in the process of updating the data collection form so that we have more information that specifically may be associated with long-term survival. So things like biologic factors, lymphovascular invasion, pathologic factors, margin status, and when you get to nodes, since 2021, we have been collecting these specific nodes harvested and which ones were positive, but that data is so new that it's really been hard to demonstrate any long-term, associations there.
For me, in terms of practice changing things, I think that the unanticipated positive nodal disease makes me believe a little bit less that intraoperative frozen section evaluation of all your lymph nodes is required. These are all patients that are clinically thought to be node negative. And sure, if you have some big bulky node, you should probably be doing a lobectomy for that patient. But someone with some, unanticipated little micrometastatic disease in a lymph node, does that person need a full lobectomy if you weren't otherwise planning on it? I don't know, but I don't think our data argue that you do need to be doing a lobectomy or that survival is going to be that different in patients who have positive lymph nodes that we don't expect. One of my favorite parts of our study was just looking at the differences in survival between different subgroups of patients. And I'd encourage you to look specifically at the Kaplan-Meier curves that we have, because there are things like age or where your pulmonary function tests lie that end up impacting a patient's survival or correlating with a patient's survival much more so than the extent of the surgical resection. And so when we're talking about small 2 centimeters, clinical stage 1A tumors, the survival for this group of people is not all the same. And it really doesn't come down to whether or not we're doing a lobectomy, a segment, or a wedge. It is much more driven by other patient factors. And I think that's a really important takeaway. So patient age has a huge difference. The PFTs start dramatically dropping your survival based on where your PFTs fall. And, many of the patients we operate on don't have FEV1s greater than 80. It's something lower than that. And so that's an important point. Also, never smokers did remarkably a lot better than patients who were current or former smokers. And so I would encourage people to look at those differences in the survival curves. And it should really guide the way that we're thinking about this disease and patients in general, because their survival is driven so much more by many other things other than how much additional parenchyma was taken at the time of surgery.
Exactly. These are great points. And I really love how both your studies, Gavit, yours and Chris's, start to really highlight the nuances in this discussion and build off of the 2 landmark randomized trials that you talked about. So my last question is, what do you think are the next steps in research that can build off of your studies?
Sure. Well, I think that the inferior outcomes that we saw with wedge resections in the STS database does beg the question, albeit acknowledging, everything that we just talked about, that perhaps it's not just a wedge, but a wedge plus the patient, plus the tumor, plus the surgeon, plus the center. So there's a lot that goes into it. But, I think that one question that may be asked, or one thing that people may first think of when they read this study is, well, if wedge resections are not that great, maybe I'll just send those high risk patients, or those patients who are have a small tumor, who would get a wedge resection perhaps in their surgeon's hand. Should I just send them to SBRT? And I think that's a legitimate question, but there's a couple things that need to be considered. First of all, the STS database demonstrates that we have extraordinarily good outcomes. Less than 5% morbidity rate, less than 1% more to 30-day mortality rate. And unlike SBRT, we can do a node dissection, and we can give tissue to the pathologist for next generation sequencing. Now, there have been a couple studies that have been performed, or a couple studies that have been randomized trials that have been opened and closed due to low accrual, trying to randomize patients to SBRT or surgical resection. So we don't have good data to guide us right here. And so, getting back to your question of, what are the next steps? I think this study, another takeaway should be that this should encourage our multidisciplinary thoracic oncology teams to be putting patients on trial, especially high-risk patients for, with small tumors, between wedge resection or surgical resections and other forms of therapy.
Right. I think that's really important. And for example, Valor and Stablemates, those two trials, SBRT versus surgery, definitely would encourage anybody here who is associated with those trials to continue accruing, and also just to learn more about these trials that are out there. Gavit, how about yourself with the next steps?
I think that more detailed data collection into the STS, like Chris alluded to, is going to be really helpful in the future. I think knowing more about the biology of the tumors that we're talking about, obviously, when you just have a pre-op biopsy, or perhaps no biopsy at all going into surgery, you don't necessarily know some of these details that end up in the final path report. But we all can recognize that the group of tumors going into the randomized trials and going into the STS data set that are stage 1 are not the same tumors. They don't all pose the same risk of systemic dissemination. And so the sooner we can identify factors that kind of guide us more based on tumor biology, whether we're using PET avidity as a crude measure, but the way to select the higher risk patients, because these people probably should be getting lobectomies, whereas a lower risk tumor, a wedge and lymph nodes, may be sufficient. So I think that starting to subgroup the way that we think about all of these tumors is important.
Absolutely. That seems to be the next big hurdle, and certainly trying to figure out who are the truly high risk patients. That's going to be something to work on the next decade, and maybe even with the help of AI in the future. So great. Well, thank you so much, Gavitt and Chris. Congratulations on your phenomenal presentations at the STS meeting, your papers, and also really appreciate today's discussion.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.